Good afternoon. Today's class is about treatment planning in orthodontics. So, what is this treatment planning? It is the outline of all the measures that can be best instituted for a patient so as to offer maximum long-term benefits. So, why long-term? Because the whatever correction we are doing has to remain stable for a longer period of time. Uh, that will indicate the success of the treatment. So, how are we arriving at this treatment plan? Based on the examination and diagnosis. So, once we take the patient's chief complaint, we examine them intraorally and extraorally. We get information on what kind of deviation is there from normal. So, that is the malocclusion. So, that gives us the diagnosis. So, based on the diagnosis, we give a customized treatment plan to each individual. So, what should be the goals of our treatment plan? So, most of the patients will come to us with a aesthetic problem. They want smile correction, they want alignment for good aesthetics. But we also have to explain to them, or our goal of the orthodontic treatment should also include function and stability. Because if we are able to give them good aesthetics without function and stability, they'll have problems in chewing and other issues. So this can lead to complicated problems like TMJ issues also. So that's why even though the patient is okay with just the alignment, we have to explain to him that the function and stability are also equally important, and our treatment duration or the treatment goals include them. So sometimes we cannot achieve all the three goals together. So we have to compromise and get the treatment to a balance between the aesthetics, function, and stability. So, what will be our treatment objectives? It is to first prioritize the problems. So, from a more severe issue to a less severe issue, and it should definitely include the patient's chief complaint. We should not leave the chief complaint. We should also address the patient's chief complaint. At the same time, we are also addressing other more severe complaints which the patient is not concerned about. So we have to explain to the patient that the solution here that we are offering is for all the corrections for the benefit of overall what do you say correction. Also, whatever solutions that we are giving should be realistic. So sometimes say the patient is a adult patient who is not growing, but there is a severe uh, class 3 discrepancy. So we cannot give a solution of mm, orthopedic appliances or a chin cup to correct such issues. So that is very unrealistic. So in this case, when there is no growth, our next step would be to plan an orthognathic surgery. So whatever treatment plan we are giving has to include all the objectives that we are uh, prioritizing and also be realistic. So before we go to the treatment planning, we have to assess the growth potential of the patient. So if the patient is growing, we can use that growth to give different appliances to modulate the growth. So this will decrease the severity of the skeletal discrepancy or decrease the severity of malocclusion. In the sense, it is intercepting the malocclusion. So that is more better. Whereas if the patient is coming in a adult stage where there is no growth, we'll have limited options. That is either mask the skeletal problem with a dental tooth movement or add orthognathic surgery to the treatment planning. Also, we have to make sure that the causative factor for the malocclusion is removed. For a hereditary factor or a etiology that we are not able to find out, we cannot do much. We can only think in terms of retention. But in case of causative factors which are known, such as you can say habits or any other environmental factor, so initial step is to remove the cause. If we are not eliminating the etiology, that will result in two problems. Either the treatment is limited, we are not able to achieve full correction, or whatever correction we have achieved will have or it will show more amount of relapse. So therefore, the etiology has to be corrected as and when we see it. So what are the different steps that we can use to plan a treatment? So this is not the final list. We'll have even more conditions that or factors which we have to take into consideration. But for a basic treatment plan, first thing that we can see is the final interincisal relationship. So that is the relationship between the upper and lower incisors. Then, depending on our model analysis, we can determine the space requirements, and then for space gaining, we can extract teeth. Also, when we are having complex movements, we have to plan the anchorage. So if we are not taking enough support from the different sources, there will be undesired side effects. Then the planning should also include the selection of appliance. Then we have to plan the retention. We already know what kind of malocclusion it is and what is the stability of the correction that we are doing. So depending on that, we have to plan the retention and periodically reevaluate whatever treatment plan we have started. So coming to the first interincisal relationship. So depending on what kind of malocclusion it is, for a class 1 case, where usually the jaw bases are normal, the upper and lower incisors generally show a normal or a satisfactory interincisal relationship. So if we see cephalometrically, we have a 130 to 135 degrees uh, interincisal angle. So it's kind of in a normal position. And with respect to the face and jaw base also, the teeth are normally aligned. So in such cases, we have to preserve whatever tooth position is there. That is, we cannot push the teeth more forward or take it more back. Similarly, if it is a class 2 division 1 malocclusion, so what is happening? We have a class 2 molar relationship and we have increased overjet, that is, maxillary teeth may be proclined. So if this kind of malocclusion is there on class 1 basis, so it is like a mild class 2 malocclusion where just tipping or retroclination of the upper incisors will be sufficient to get a good positive relationship between the upper and lower incisors. Whereas in a mild class 2 base where the maxilla or mandibular are forward or backward to a more degree, so here maybe only upper incisor retroclination will not be sufficient. We have to bodily get the upper incisor more back because in class 2s the upper teeth will be forward. So this can be achieved with the help of extractions, and that will be sufficient to correct the interincisal relationship. So this is like a class 2 discrepancy which can be camouflaged with tooth movement. Whereas in case of severe class 2 basis where the maxilla is too large or the mandible is too short or a combination, where just the tooth movement is not sufficient to correct the interincisal relationship, we have to also plan growth modification in case of growing children or surgery in case of non-growing adult patients. So class 2 division 2 is similar to class 2 division 1. So in class 2 division 2, we are having a class 2 molar with uh, upper anterior teeth which are retroclined. So in case of a class 1 or mild class 2 base, skeletal base, just uprighting the teeth or moving the upper incisor root lingually or palatally should be sufficient to bring about good interincisal relationship. Whereas in case of severe class 2 base, we are converting the class 2 division 2 into a class 2 division 1 malocclusion by proclining the upper incisors. And then to that, we are adding either growth modification or surgery depending on the growth status of the patient. Like class 2, we also have a class 3 malocclusion. So a class 3 malocclusion, uh, if the jaw bases are normal, but we are seeing a slight forward positioning of the mandible, which is the pseudo class 3. So this happens because of occlusal interferences. So once we remove the interferences, the mandible will close in a normal position. So another problem could be, suppose there's a edge to edge relationship, and because of the edge to edge relationship which is unstable, the lower jaw will tend to move forward. So this can be eliminated by proclining the upper incisors. so that that edge to edge relationship is modified into a positive overjet. So here, because the relationship of the upper and lower incisors is more stable, mandible will not move forward. So that is for a mild class 3. Whereas for a severe class 3 case, which can be managed with dental correction, we tend to procline the upper incisors and retrocline the lower incisors so that there is a good interincisal relationship that is achieved. So this is a camouflage treatment. Or if this is not sufficient, we have to go for growth modification in case of growing children. So that would be protracting the maxilla or giving chin cup to uh, prevent mandibular growth. Whereas in more severe cases, in growing children, again, we give any orthopedic appliance, or in non-growing patients, we tend to uh, resort to surgery to correct the jaw base. So the same thing, if we see in the picture here, the first in the top row, the first diagram is proper class 1 malocclusion with class 1 basis and the teeth in good incisor relationship, which we have to preserve. Whereas in the second picture, it is a class 2 base with mild class 2 or a class 1 base. So just retroclining the teeth, that is, we're just tipping the upper incisor to get it into a good relationship with the lower teeth. Whereas in the third picture on the top row, it is a more severe kind of a class 2 base where we are trying to retract the upper incisor to get it into proper position. In the middle row, the first one is a more severe kind of a class 2 base where just the tooth movement is not sufficient. So here, along with that, we are either trying to move the mandible forward with the help of either surgery or growth modification. Whereas in the middle row, the middle diagram is about class 2 division 2 type of malocclusion on a mild skeletal class 2 base where just a palatal root torque or uprighting the incisor is sufficient. Whereas in a more severe kind of a class 2 base and a class 2 div 2 malocclusion, we have to procline the upper anterior, along with that push the mandible forward either with growth modification or surgery. Similarly, in the third row is a class 3 case where initial diagram shows upper anterior proclination to relieve the interference. That is, we are correcting the pseudo class 3. Whereas in the second picture, it's a more severe kind of a class 3 where the upper incisor is proclined and lower incisor is retroclined to get a positive overjet from a reverse overjet. So the incisor relationship is, again, it is dependent on the severity of the skeletal discrepancy. So in this diagram, we are seeing the two differences, that is class 2 division 1 and division 2 type of malocclusion. So once we are planning where the incisor is supposed to stay, we have to measure our space requirements. So certain conditions in the arch require space, such as crowding. So crowding basically suggests the arch length tooth material discrepancy. So for every 1 mm of increase in tooth material, we need 1 mm of arch length or 1 mm space in the arch. Then coming to rotations. Anterior teeth, the mesial distal dimension is wider than the labiolingual thickness. Therefore, when the anterior teeth rotate, they occupy less space. So the derotation of anterior teeth will require more space in the arch. So how much space we need will depend on how much space is available in the arch and how much of the tooth is, how much is the mesiodistal width of the anterior teeth. So leveling the curve of spee, generally a flat spee is wider than the curved arch. So therefore, when we are trying to level a deep curve of spee, it will take some space. If we are not giving enough space, it will tend to procline the lower anterior teeth. Then for the correction of proclination, we need space. So for every 1 mm reduction of the proclination, we need 2 mm space in the arch. Coming to molar correction, so molars we move to achieve a stable occlusion. So if we are mesializing the molar for any reason, we will take some space. Or if we are dislicing the molar, we are going to gain space. Then anchorage is also important when we are planning space requirements. So usually when we are having even a maximum anchorage situation, there is at least 25% loss of the extraction space because of anchor loss. So therefore, in case of situations where there is a chance for the anchor tooth to move out of its position, we have to augment the anchorage or consider that in the space requirement. So once we know how much space is needed to correct that malocclusion, we have to plan the different techniques to gain space. So it could be either with the existing spaces that are present. So we can close the spaces and retrocline the teeth. For minor space requirement like 1 to 3 mm, we can do proximal stripping. Or if for narrow basis, we can expand the arch and gain space. Extraction is considered for more requirement of space like 7 to 14 mm space requirement. And not only for intra-arch malocclusion, for some inter-arch corrections also, we tend to extract teeth. Then distalization, again molar distalization, we can push the molar posterior teeth back to gain space in the arch. This is especially indicated when the profile is very good. Then molar uprighting, so when the molar is slant, it takes up more space in the arch. So when we upright it, it is going to give us some space. Derotation of posterior teeth, so posterior teeth when they are rotated, they take up more space, and when we are correcting it, we get excess space in the arch. Similarly, uh, proclination of anterior teeth will also give us space. Why? Because when we procline the teeth, it will take up more larger circumference, and there is an increase in arch length. So both of which will contribute to increase in the space. So once we know how much space is required and how we can gain the space, by which method we are gaining the space, from there we have to plan which tooth or which segment of the arch has to be moved in which direction. So in this picture, this is all the methods that we use to gain space. So first picture is showing the proximal stripping where the mesiodistal width is reduced. In the second picture, it is showing the proclination of teeth to accommodate the canine which is out of arch. So you can see the increase in the arch length. The middle row, the diagram is showing molar distalization procedures where already space is gained between the two premolars because of distalization of the molars. In the bottom row, we can see how the molar uprighting is giving space in the arch and extraction for correction of malocclusion. Also, when we are seeing the transition from the deciduous dentition to mixed dentition, the permanent anterior teeth generally are larger. So how they are accommodated in the arches, also because of their inclination. Compared to the deciduous teeth, the permanent incisors are more labially inclined. So when they are more labially inclined, they take up a larger circumference and the arch length is increased, giving enough room for them to align in the arch. So the same thing that we see behind a well-aligned arch, for the same mesiodistal width, when the teeth are pushed forward or proclined, they are taking up more space. So the spacing appears between the teeth, whereas the same mesiodistal widths of the teeth, when they are pushed inside into the arch or they are retroclined, they tend to crowd. Then in the bottom picture, we see how a curved arch, when it is flattened, it takes up more space. So if you are not giving enough space for the correction of curve of spee, it will tend to procline the lower anterior teeth forward and tip the posterior teeth distally. And the final picture shows how the derotation of anterior teeth will require space. So now, suppose for the space gain, we are considering extracting teeth. We need to know which tooth to extract and how many teeth to extract. Again, there is a easy guideline for this. based on what kind of malocclusion or jaw base it is. Suppose it is a class 1 malocclusion, where we already have class 1 canine and molar relationship, which we have to maintain. So in that case, we can go for symmetrical extractions of upper and lower first premolars and retract the entire anterior segment back. So here we are achieving our uh, retraction of teeth along with the maintenance of class 1 molar and canine relationship. That is, the occlusion is maintained. Whereas in class 2 conditions, suppose it is a full cusp class 2, so generally, cusp to fossa relationship is required. So in a full cusp class 2, we can hold the class 2 molars. So here, because the maxillary segment is forward, we have to get the maxillary segment back. So for that, we can just remove two premolars in the maxillary arch and close the space so that we get a class 1 canine relationship and a class 2 molar relationship. But sometimes there can be crowding in the lower arch also, which needs some space. And the molar may not be a full cusp class 2, it will be a half cusp class 2. So in that case, we need to even move the molar. So here in such situations, we can extract in both upper and lower arches. So the upper arch entire space we'll use for retraction of the anterior teeth, whereas the lower space, after whatever decrowding we are doing, the remaining space we use to protract the molars. So here we'll achieve a class 1 molar and class 1 canine relationship. So if you see in terms of anchorage, upper arch usually it is maximum anchorage, whereas lower arch it is minimum or group C anchorage, because we are getting the molars forward. Reverse of this is class 3. So here, because the mandible is positioned forward, we can extract the lower premolars and get the anterior segment back while maintaining the molar relationship. So here we'll have a class 3 molar and class 1 canine relationship. But in some cases where we have to go for extraction of both upper and lower teeth, suppose upper there is crowding or proclination. So in that case, upper premolars we are extracting and using partial space for upper anterior correction and remaining for the molar protraction. And lower space we are using completely for lower anterior teeth retraction. So apart from this, we can also have asymmetrical extractions, like in a class 2 subdivision case, we can either extract just one premolar or we can go for extractions of three premolars to correct the malocclusion. Sometimes, in case of just lower anterior crowding and a class 1 situation, we just need 4 to 5 space. So in that case, we can just go for a single lower incisor extraction and close the space so that the upper is maintained and the lower arch is aligned while maintaining the class 1 canine and molar relationship. So depending on the situation, again, we can have a combination of space gaining methods. That is, we can uh, extract the teeth as well as do some amount of proximal stripping, or we can use expansion along with extractions. So the combination depending on how much space we are needing. Then again, anchorage. So anchorage requirement we have to thoroughly plan, because we don't want any unwanted tooth movement. So these unwanted tooth movements can take up whatever space we have created for correction of the malocclusion. So this anchorage requirement is based again on different factors, like the number of teeth that are moved. More the number of teeth, we need more support. So if the number of anchor teeth that we are using is not sufficient, we can augment the anchorage with help of extraoral appliances, muscular anchorage, or absolute anchorage with help of mini screws. Then again, type of teeth. For long roots such as canines or multi-rooted teeth like molars, they need more support or anchorage for their tooth movement. And also the type of tooth movement. Generally, tipping type of tooth movement will not require much anchorage, whereas bodily tooth movement will place more strain on the anchor teeth. So therefore, we have to hold the anchorage or provide more teeth to the anchorage unit. Again, duration of treatment. Greater the duration of treatment, there is more strain acting on the anchorage anchor tooth. So again, here we have to uh, augment the anchorage. Next, coming to the selection of appliance. So selection of appliance is again based on different criteria. First thing that we can see is growth potential. So when the child is having growth potential, it is better that we give some kinds of removable appliances which will do simple movements, or growth modulating appliances like orthopedic appliances or functional appliances like twin block activator, etc. uh, then based on the tooth movement, suppose there's just a single tooth that has to be moved, or it's a simple tipping movement, so in those cases we can give removable appliances which will very easily resolve the issue. Whereas for multiple tooth movements or for severe crowding, severe proclination where many teeth are moved at a time, so that will need more of a fixed appliance therapy. Then oral hygiene, again removable appliances, they allow better oral hygiene compared to fixed appliances. But in case the fixed appliances has to be given, then the oral hygiene instructions have to be uh, emphasized at every appointment so that the deleterious effects are minimized. Again, coming to the cost, depending on the patient's requirement, generally removable appliances will cost lower. But if you're seeing aligners that have come into picture nowadays, they are more expensive. Even though they are removable, they are more expensive. So depending on what the patient can afford, we'll have to slightly modify the kind of appliance that we are using. Also the aesthetics. Nowadays patient want more aesthetic options like ceramic braces or lingual appliances or aligners. So again, based on what the patient wants, we can select the type of appliance. So once the appliance is selected, at the beginning itself, we have to plan the retention also. Why we have to plan the retention is we know what kind of movements we are doing. Certain movements like space closure, rotation corrections, they tend to relapse very easily. So for that, we have to plan a retainer which will give a long term retention. So why there is a problem of relapses? It is because of the stretched periodontal ligament. The reorganization of periodontal fibers will take almost a year. So meanwhile, we have to hold the teeth in position. Also, unstable occlusion, that is we are not providing a cusp to fossa relationship, or the interincisal relationship is not good. So that will lead to relapse of the malocclusion, or continuation of growth pattern, or the etiology is not properly removed. So both of which will again result in relapse. So apart from the normal fixed and removable appliances that we provide to the patient, we have sometimes we also have to give certain additional procedures like frenectomy in case of a very thick labial frenum, which is causing the midline diastema. So by removing this frenal attachment, we allow proper closure of the upper incisors. The scar tissue that is formed after frenectomy will also help with the retention of that midline diastema correction. Similarly, for a rotated teeth, to allow the periodontal ligament fibers to readapt to a new position, we do something called as pericision or circumferential supracrustal fibrotomy. So the superficial gingival fibers and the periodontal fibers are sectioned so that they join and readapt in a newer position. So this way, the stretched fibers that cause relapse, that stretch is minimized on the fibers. So once we have planned the retention, the treatment will progress. So during the treatment also we have to reevaluate periodically. Why? To check whether all our treatment objectives are being met or not. So sometimes there are some undesired tooth movements, or there are some new tooth problems that can arise. So when we are periodically checking these problems, we can eliminate them in the initial stages itself, or slightly modify our objectives to reach our final goal. So changes can be made if the desired results are not happening, or if some unforeseen problems can arise. So this is the basic steps that we have to follow to reach to a treatment plan. But depending on individual situation, individual malocclusion, further criteria or further factors will be considered. Thank you.